And so if it's reviewing a 700-page chart, it may not be perfect, but believe me, I can't do that in the 3 minutes I have to do it. So by and large, the tools have gotten much, much better than they were a few years ago. I think you can trust if you're being seen at a place like UCSF, we're not putting it into common work, into our workplace, unless we're pretty confident that it's generally reliable and trustworthy, and that there is a doctor looking over its shoulder before making a final decision. But we sort of buy the idea that even if the excuse, the AI told me to do it, is not going to work very well in court.
Hello, and welcome to Not Born Yesterday, a podcast dedicated to older adults and the challenges and joys of aging. I'm Miriam Goodman. Not Born Yesterday examines the problems and solutions of growing older today. We bring you the wisdom and voices of experts in the field of aging and offer tips on how to feel your best, use your lifetime skills and experience, and make the coming months and years as fulfilling as possible.
I'm Lynn Winter-Gross. Not Born Yesterday is brought to you by Next Village San Francisco, a local nonprofit providing older adults with support to help age in place, and by Assisted Living Locators, a San Francisco Bay Area senior care advisory service, helping families make informed decisions about senior care and living options.
Today on Not Born Yesterday, we're looking at two subjects that affect older adults today: artificial intelligence and healthcare. Whether it means predicting disease earlier or remote monitoring, AI is reshaping medicine in many ways. While many dismiss artificial intelligence as too complicated or even scary, we all have questions about how it will affect our future, what are the pitfalls of AI, and who benefits, especially for older adults, and what happens when a patient cannot advocate for themselves.
Our guest today is Dr. Robert Wachter, professor and chair of the Department of Medicine at the University of California, San Francisco. Dr. Wachter has combined his research and expertise with more than 100 experts and has written a book on the benefits and challenges of healthcare and AI, titled A Giant Leap: How AI is Transforming Healthcare and What That Means for Our Future. The book is a guide to how we will all be affected in the future of medicine. Dr. Wachter, welcome to Not Born Yesterday.
Thank you. Thank you both for having me. Look forward to it.
Before we talk about your findings in your book, can you tell me if AI will mean my healthcare provider will give me more than 15 minutes when I have an appointment and I won't have to wait 3 months to see him the next time?
Probably not, but I think it's more likely that you're going to be able to interpret what he or she says, be able to ask better questions when you come in, and probably get a fair amount of your healthcare from your computer rather than necessarily depending on the doctor to deliver all of it. So it's going to change the dynamic of your relationship with the doctor, but I think the 15 minutes is largely determined by the economics of healthcare, and I don't know that that's going to change.
You say get it on your computer. I've been told don't look at my blood test results on my computer because the doctor should interpret them for me.
Yeah, so starting about 10 years ago, by federal law, you get your blood test results. I think that's generally a healthy thing, but what's been unfair is you get the results and you've got absolutely no help in interpreting them. I think one of the things AI can do quite well is interpret them for you, particularly if it has access to your past record. So, for example, one person's blood pressure might be high for them, but for another person, it's okay. And so it's going to be important that whether it's a doctor or AI, that they know your past history and the context in order to interpret any lab result. That is happening. There are now going to be tools in your patient portal where you get that information, where you see the result of the blood test, that you'll be able to click a button and say, tell me what it means that my magnesium is low. And it won't just give you the textbook answer. It will be able to look at your past history and know for you, is that something to worry about or not?
So how are you using it, AI in medicine?
We're using it all the time, which is remarkable because the new AI is only 3 years old, really. I think all of this dates back from November 30th, 2022, when ChatGPT was first released to the public. Until then, AI was kind of a dead issue in medicine. We weren't really using hardly any of it, a little bit to predict a few things like the chance that a patient might have to be readmitted to the hospital. But by and large, we were in what sometimes is called the AI winter. And then when ChatGPT came out, it became clear that this new technology had really remarkable skills and was intersecting with the healthcare system, kind of in desperate need of it. And so the way I use it today when I'm practicing medicine here at UCSF We all have access to an AI scribe, and I like to use them. So if I'm taking your history, if you're my patient, I'll ask you if it's okay if I record the conversation. I'll put the phone down between us. It will record our conversation and create a properly formatted note, which might seem like a little bit of a nothing burger because, voice to text is old, but it can't just be a recording of our conversation. It's got to, unfortunately, when you talked about how wonderful your grandchildren are, it'll cut that part out. It will, if you said in the beginning you're short of breath, and then 10 minutes later you said you have chest pain, it'll combine those two because the AI knows that those two are related to each other. So it does that. If I'm reviewing your past record, believe it or not, 1 out of 6 patients has a past medical, 1 out of 5 actually, has a past medical record longer than Moby Dick. So I may have 3 minutes to review 500 pages, and that's impossible, obviously. So there's a little button I can push and have AI summarize your past medical record. And so I'm using that. Probably the main way I'm using it is there's a tool that unfortunately is only available to clinicians, not to patients yet, but it's called Open Evidence. And it's basically GPT built for doctors. And now I can pick up my phone or go on the computer and say, this is a 75-year-old person with lung cancer who's on this medicine and that medicine. And she comes in with a fever and a headache and is short of breath, and her creatinine is 1.7. What do you think is going on? Any tool up until 2 or 3 years ago, even the best electronic textbooks, would have sputtered with that. They couldn't understand the context. And now these new tools can understand a plain English prompt, and give me an answer that in general is quite reliable.
So as exciting as artificial intelligence is, it seems to make a lot of mistakes. I read almost every day somebody, lawyer, had looked up some cases, and it turned out the cases didn't exist, and he was trying to use them as precedents. Other things happen. So if something happens in medicine and a doctor follows it and it's wrong, who's to blame?
Yeah, you're probably going to blame, and if it really went terribly wrong, sue the doctor. And I think that's the way we think about it, that if we're using an AI tool, but ultimately we are the final decision maker, meaning the tool is not acting autonomously, which in general in medicine they don't yet. Then we're at the end of the road. We're the ones making the decision, making the recommendation. I mean, the system itself, the malpractice system, is pretty broken, but it gives us a pretty hefty incentive to only bring in tools that we really trust, that we think are going to give us the right answer, not the wrong answer. What you're referring to is generally called hallucinations, where the AI not only gets it wrong, but kind of makes up stuff. That was a huge problem in the first couple of years. It's not very much of a problem today. It's not like it's perfect, but I'll confess to you that neither am I. And in my book, I often quote Biden's old line, "Don't compare me to the almighty, compare me to the alternative." And so if it's reviewing a 700-page chart, it may not be perfect, but believe me, I can't do that in the 3 minutes I have to do it. So by and large, the tools have gotten much, much better than they were a few years ago. I think you can trust if you're being seen at a place like UCSF, we're not putting it into common work, into our workplace, unless we're pretty confident that it's generally reliable and trustworthy, and that there is a doctor looking over its shoulder before making a final decision. But we sort of buy the idea that even if the excuse, the AI told me to do it, is not going to work very well in court. So it's really our call.
So healthcare is deeply personal. How do we deal with the privacy as AI seems to gobble up all sorts of personal data?
Yeah, well, your data already is in the hands of an outside company, because if you're seeing a doctor or a health system like mine, your data is being stored in what's called an electronic health record. If you're on my chart, that's built by the electronic health record company. So it's already there. The difference, I think, is that those companies operate under a law called HIPAA, which basically says you have to keep patient data private. And if we leak it out, there are pretty hefty penalties that we're at risk for. But that is a matter of trust. And you should do it if you think the benefits of having your data in there outweighs the downsides. The benefits are if you go to Claude Health or GPT Health and your data are there, and you say, I woke up today with a headache, it won't just give you a generic headache answer. It will give you an answer based on that it knows you have diabetes, or knows that you have had headaches for 20 years, or you're on a certain medication that can cause headaches. So like a lot of things in life these days, you've got to decide, are you willing to take maybe a small risk on privacy for the benefits that you might get of having these companies have your data? I think that's an individual choice.
Are you finding resistance from your colleagues or from students that you're teaching?
Colleagues are largely embracing this. They believe that this generally makes them better at their jobs. The tools like the AI scribe, which creates the note that I talked about, is wildly popular because the alternative is you've turned me into a very grumpy data entry clerk. And patients notice that their doctor seems to have his or her head down in the computer checking boxes rather than listening to me and looking me in the eye. So I think even in fields where people, I think, are legitimately worried about being replaced by AI, there have been lots of predictions that AI is going to take jobs of radiologists. I can tell you that at UCSF, we can't hire radiologists fast enough. And the radiologists are begging for help to be able to get through all the scans they have to get through. So, I think worries are, over, is it trustworthy? Is the answer, the right answer? And I think, as I said, those worries are less than they were a few years ago. I don't think there's that much worry among doctors and nurses that it's going to take their jobs. I think there is worry, probably appropriately, for the people working in the call center or the billing department. There's a lot of back office people in healthcare just dealing with the mountains of bureaucracy and paperwork. I'm hoping that some of that gets replaced, as sad as it will be if they lose their jobs. But that's a lot of the costs of healthcare, are all of that bureaucratic stuff that adds very little clinical value. On the student side, yes, I think we are worried about it and really fretting about this a lot. And probably not that different than high school teachers are, which is, how are there things that we don't have to teach our medical students anymore because the AI is so smart, but worried that if we stop teaching them, you almost end up with a death spiral when the docs are not as good as they need to be. And I think one of my insights over the last few years is, if I use the same AI tool that you're using, my results may be terrific, yours may not be, because I know exactly what to put in. I may have 200 facts, or you may have 200 facts. For a patient, there's no way they can know which 6 facts should go into the prompt. And I do, from lots of school and residency and 40 years of practice. And we're beginning to see that where the results that patients are getting when they use these tools often are not great. That gave the wrong answer too much of the time, or it told them they could stay home where the right answer was to go to the ER. So I think there is, one of the things I say to medical students is, experts are better at using these tools than novices. And if you don't learn medicine, you're still a novice. But that's roundly debated. There probably are some things that we can take off the curriculum, like, do they really need to memorize every drug? No, I don't think so. I think now, when it comes time to prescribe a drug, you've already settled on the diagnosis. I think you can look up what is the right drug for this patient's blood pressure or this patient's cholesterol. And the level of time, the amount of time that we spend on that kind of memorization, I think that can go down. But what I don't think can go down, for the time being at least, is the doctoring skills of sort of understanding, if a patient comes in with belly pain, what are the next 10 questions you should ask? And what is the answer? If they answer X, what are then the next 5 questions you should ask? And how do you do diagnostic reasoning under uncertainty? It's a lot of what we teach. I think that part should not be taken off the curriculum. But I can tell you, this is topic A in every medical school in the country today.
Well, topic A for some of our listeners is, how come doctors don't know enough about older adults and older adult diseases? So I'm wondering, for example, falls. Falls are the curse of the older person. They worry it can lead to death. It can lead to long-term injury. So is there anything AI can do to help prevent falls?
Sure. I think it'll get there. I mean, one of the things that's going to happen, already happening, I don't know if either of you wear Apple Watches or rings, or have, right now it can tell probably your kids that you fell. And I've gotten a couple of my notices on my phone that my mother in New Jersey, 3,000 miles away, fell like 10 seconds ago. But that doesn't help that much. Better if it could predict her being at risk for a fall. And as the tools get better, particularly if they're coupled, if you're comfortable having cameras in your house that actually look at your gait, we're going to get to the point where these tools can actually predict who's at high risk for a fall. Then the question is, what do you do about it? I mean, do you pad the house, or are there activities and exercises and physical therapy that you can, or maybe the falls are related to the way your house is set up, and you shouldn't have that throw rug in the middle, or they're related to a drug that you're on and your blood pressure is getting too low. There's a whole lot of stuff that if we can predict these things better, then I think the AI will put us in a position to then trigger, all right, I need recommendations about how to make my house safer, or I need recommendations about how to get stronger and help with my balance. And that's a hard thing to do because I'm lazy and I don't like doing yoga. Maybe the AI, it periodically gives me an attaboy, an attagirl, and says, it's really important you do this because this is the best thing that we know that can help prevent falls.
How do you think AI is affecting the doctor-patient relationship?
I mean, I think the challenges to the doctor-patient relationship, I'd say most of us welcome this theoretically, meaning and there are some doctors who obviously have different attitudes, but, I think for me and a lot of my colleagues, having a more informed patient who kind of knows the right questions to ask, or maybe I don't have, the time to describe or explain everything and they can get the explanation you got. I think that's all good. Where I think there are going to be challenges. I was talking to somebody yesterday who said, she searched in GPT or Claude before she went to see the doctor and found that she had some disagreements with what the doctor's doing. If your doctor seems unhappy that you want to spend the first 10 minutes discussing what you found when you search GPT, it may be your doctor's not a Neanderthal. It may be your doctor's saying, oh, Jesus, I've only have 15 minutes for this. And she has 5 diseases and is on 12 medicines. And I got to spend the first 10 minutes talking about what she found on Gemini. I think that some of this is just practical and logistical kind of stuff. But anytime it's challenging for physicians because we were taught that, the reason you did all this school is you then became an expert and your patient is not. And now, patients have a version of expertise that they didn't have before. And I think in every industry, as those hierarchies dampen, there's some challenges there that we're going to have to muddle through. It turns out if you have a good doctor, your doctor still is better than your bot.
We haven't talked about the ethics of artificial intelligence at all. And the promise is to do no harm in caring for patients, can AI be developed so that it is ethical?
Well, I think the only ethical North Star I have is what can we do to deliver the best healthcare and the best health to people, and hopefully at the lowest cost. So I think AI is ethical if it lets us do that, and unethical if it doesn't. And I'm pretty enthusiastic about that. It will help us do that. It helps us do that by getting to, if it can help me get to the right answer, if it can help you get the advice you need and you don't have to go and see the doctor. I think all those things are, highly ethical. If, it is unethical if a teenager is using a chatbot and the chatbot says, you should go harm yourself. That's unethical. That needs to be stamped out. On the other hand, it's highly ethical if people can get access to mental health advice for $20 a month rather than try to see a psychiatrist in the Bay Area, next available appointment, 6 months, and it'll cost you $400 an hour. So if it makes care better and safer and less expensive, then it's totally ethical.
So your book, A Giant Leap, looks at artificial intelligence as it is today and tomorrow. But one of your earlier books talked about hype, hope, and harm. So what's the difference between when you wrote this, when it was just computers and not so much AI, and now? What's changed, do you think?
Yeah, the new two things changed, I think. So the prior book was called The Digital Doctor. It really was about the electronic health record and us going from paper to digital. And this book is about us going from digital to digital with the new AI. Two things changed. One is it's the new AI. And it was so important for healthcare because so much of our data either comes in the form of conversation, and no prior AI or computer could analyze conversation. And it comes in the form of written narratives, written notes, and no former AI could deal with what is called unstructured data. The other thing that's changed is I think it's obvious the healthcare system is massively broken. Try to find a primary care doctor in most cities. It's nearly impossible. Try to have more than 15 minutes with your doctor and you have really complex problems. It's impossible. So I think the system is so broken and just simply can't deliver on what patients need it to do and also is bankrupting the country, people, governments, businesses. So it's a combination of this technology now is pretty magical, and the needs of the healthcare system are such that I actually don't think we can address them without this AI. And it's that combination that makes me far more optimistic about this than I was in my prior book talking about the electronic health record.
Dr. Wachter, thank you so much for your insights and for sharing them with our listeners. Our guest was Dr. Robert Wachter, physician and author of A Giant Leap.
Thanks so much for having me.
Today on News You Can Use, we just heard about something very new, but there's still something old that's around, and we should know more about it: alcohol abuse. According to the National Institute on Alcohol Abuse and Alcoholism, alcohol use and misuse is increasing among seniors, especially among older women. Binge drinking, or even just drinking with more frequency or increased amounts, combined with the physical changes in our bodies, often means we feel the effects of alcohol sooner than we used to. So here are a few things you should know about how alcohol affects us differently as we age.
First, older people are more sensitive to the sleep-inducing effects of alcohol, as well as its effects on balance, coordination, attention, and driving skills. This means we are at higher risk for falls, auto accidents, and other injuries that may result from drinking. In addition, due to changes in our bodies, some older adults may have higher blood alcohol concentrations after consuming the same amount of alcohol as younger drinkers. And this applies whether you're drinking wine, cocktails, or just straight shots.
Alcohol misuse by older adults is associated with faster cognitive decline, such as problems with memory, thinking, and judgment. For example, major life changes like retirement, the death of a loved one, or health issues can prompt a person to begin, continue, or increase alcohol use to cope with the stress and feelings of loneliness, boredom, anxiety, or depression. Unfortunately, the temporary relief produced by alcohol is short-lived and leads to a cycle of trying to fix the problem that in fact the alcohol is causing.
Similarly, many adults experience problems with the duration and quality of their sleep as they age. These problems lead some older adults to self-medicate with alcohol in an attempt to improve their sleep. Drinking to help with poor sleep, however, can actually make sleep problems worse. In addition, alcohol misuse can increase the risk of medical conditions that are common with aging, such as chronic pain, cardiovascular disease, diabetes, and respiratory infections. Alcohol misuse is also associated with an increase of various types of cancer, even at low levels of consumption.
As we have warned before, especially when it comes to falling, many older adults take medications that could interact with alcohol. These could cause the medications to not work properly or make them dangerous or even deadly. And medications used to treat anxiety, pain, or blood pressure problems could further increase the risk of falls or injuries when combined with alcohol. Clues to a possible alcohol problem may include memory loss, depression, anxiety, poor appetite, unexplained bruises, falls, and inattention to cleanliness or appearance. If you're concerned about your own drinking patterns or those of a loved one, talk to a healthcare provider.
And that's our podcast for today. Our thanks to Dr. Robert Wachter, author of A Giant Leap. You can learn more about Next Village San Francisco at their website, nextvillagesf.org, or call them at 415-888-2868. To learn more about assisted living locators, contact Senior Care Advisor Brent Hensley at BrentH@assistedlivinglocators.com. That's BrentH@assistedlivinglocators.com. Our theme music is from Hook Sounds, and Claire Winslow is our engineer. And we want to thank you for listening. We'd love to hear what you would like us to discover and discuss. Please contact us at notbornyesterdaypodcast@gmail.com. You can follow us on Facebook, Instagram, and LinkedIn, and subscribe wherever you listen to podcasts. All of them are free and let us know our audience better. Be well, stay strong, and remember, you weren't born yesterday. I'm Lynn Winter Gross.
And I'm Miriam Goodman.